Good afternoon and welcome to HIT Policy Update, a complimentary webinar from healthsystemCIO.com sponsored by Lexmark. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemCIO.com and I'll be your moderator today. We encourage you to ask questions. It's a great topic for questions. You can send them in as they occur to you by typing them into the Q&A box in the lower right-hand corner of your screen. Leave the default set to all panelists. Send them in as they occur to you and I will ask them later in the program. You can download the deck by using the URL on your screen. I have sent it out in the chat box and there in the Q&A box, and there is also a shortened URL at the bottom of each slide. And we are recording this event and we'll get it posted to our YouTube channel as soon as possible, definitely within 2 business days, if not sooner, and you'll get an email when it is ready to be viewed with a link on how to find it. Just so you see how we're going to spend our time today, we're going to go about 40 to 45 minutes. First, we're going to hear from Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center. And then we're going to hear from our sponsor, represented by Darren Sinkler, Healthcare Industry Director with Lexmark, and then we will have our Q&A. So without further delay, we're going to turn it over to our good friend, Dr. Halamka. Thanks for joining us again.
Well, happy to be here, and I didn't realize it was going to be recorded, so I can't say politically incorrect things like, after 10 years of serving in the Bush and the Obama administration, I look forward to the Trump administration. I'm moving to Canada! Anyway, so today we are going to talk about Stage 2, Stage 3. We're going to talk about the ONC rule. We're going to talk about all the things going on in Congress. Since we last talked, there has been 1,500 pages of new regulations finalized. But keep in mind, in a first for CMS, this has never happened before, they have published the Meaningful Use Stage 2-3 final rule as a final rule with comment period. If it's a final rule, how can it have a comment period? So what does that tell you? It's not a final rule. And I thank God, because as we'll go through today, there are a variety of challenges in that final rule. And I'll predict, and you'll see why, that the Meaningful Use Stage 3 activity will be deferred, delayed, and probably consolidated into some other federal government programs, because there's just a number of assumptions in Stage 3 that make it really impossible to implement in most eligible professional and hospitals. So let's begin with diving into what were the modifications on Stage 2 and then into Stage 3. So interesting, instead of publishing 2 separate rules, here are the Stage 2 revisions, and then here's Stage 3, CMS put out one final rule with comment period for Stage 2 and 3. The Stage 2 things you need to know about is that there was a lot of consternation from professional societies that a year-long reporting period just was too hard. I mean, you're trying to implement new EHR technology, new workflows, and having a full year, I really want a 90-day period. And so, yes, they did change it so that all providers in 2015 have a 90-day reporting period. That's very helpful because it does mean that you had a chance to put in your new technology, your new workflows, your new products and services, and you only had to run them for 90 days. One of the confusing aspects of meaningful use, and there are many, is that you got Stage 1, Stage 2, Stage 3, you got providers that began in 2009, 2011, 2015, and wait, if you run a multi-specialty practice with 500 different providers, you could have different rules and different requirements apply to almost, every provider in your organization. How do you even keep track? So what they did for these Stage 2 modifications, they really eliminated this Stage 1 concept, said every provider is going to attest to exactly the same criteria, a modified Stage 2 set of criteria. Core and menu measures have been simplified into just 10 objectives. So there you have every eligible professional in your whole organization has a 90-day reporting period in 2015 on 10 objectives. Very straightforward. I mean, I think the Stage 2 stuff, it's all good simplification. Now here is sort of, as we'll talk about with Stage 3, we get into the patient-family engagement modifications, and those are interesting. Back in the day, when Farzad Mostashari first proposed some of the stage 2 criteria, he was very enthused with patient-family engagement. And we all love patient-family engagement. There's nothing wrong at all with sharing data with patients and families. Challenge is, most software products didn't do it well. Patients and families weren't quite sure of the value proposition. And so when Stage 2 came out and it said 5% of all patients and families must view their medical record and 5% must send secure messages, a lot of clinicians said, well, that's tough because I can't actually change the behavior of patients. And if I told my mom, who's in her late 70s, I want you to go home right now and chart your serum sodiums for the last 5 years, she would say, why would I want to do that? What's the value to me? And so I think what we saw was, sure, for some mature organizations that have been doing this for 20 years and have figured out how to turn data into advice, wisdom, ease of access, so that you're not showing raw data. It's things like, oh, your cholesterol's high and we have this cholesterol treatment program with statins and diet and exercise. Fine, that's good. But not a lot of products, services, organizations have done that. So CMS said, instead of 5% of all patients having to view their record and send secure email, we will change the rule to 1 patient. Mrs. Smith, can you go look at this? Okay, we're done. And so fascinating, that you just have to do it once. And then, as we'll talk about in a second with Stage 3, it gets a little crazy because we couldn't do 5%. That was too hard. We changed it to 1 patient. But now in 2017, we're going to change it to 10% of all patients have to look at their record and 25% have to interact with secure email. So Stage 2 changes to 1 patient, helps with adoption, reasonable thing to do. The Stage 3 stuff, a little too aggressive. A lot of the Stage 2, what I'll call required data entry activities, have been removed. There were a variety of things that were carryovers from Stage 1, like record demographics and vital signs and smoking and clinical summary, structured lab results, patient list, patient reminders, these sorts of things. They have been removed. With the idea, CMS's logic is we've kind of topped out on those. We've got reasonably good adoption of doctors entering problem lists and medication lists and demographics, so we don't need to continue to have them put that in attestation. And then just so you guys know the dates, so you can prepare. Remember, it's 90 days, calendar year 2015, and the attestation will be available on January 4th, 2016, and the deadline is February 29th of 2016. So folks will probably be able to hit that Stage 2 milestone with these new modifications, so that's all good. Now, Stage 3, we go through a couple of these things, and you'll see some are very reasonable, like protecting healthcare information. We all know, pick up the New York Times on a given day, some new company has been breached through malware or social engineering. So the notion that you'll create a plan identifying your risks and then the mitigations to reduce those risks, that's all good. It's not saying that every doctor's office and hospital has to spend millions of dollars on security enhancements or create a massive security team. It's just that you better have a plan. And I've been through audits, internal and external. I've talked to OCR and OIG and all these various government entities. And really, when they come in, they aren't saying, oh my, do you have the latest firewall from Cisco or the latest encrypted storage from EMC, or do you have, these great new security detection protocols in place? No, they just want to know you've identified your risks, you got a plan, you're working to make your IT infrastructure, your policies, and your education as good as it can be. So that's all good. The next, e-prescribing. This particular modification takes the e-prescribing percentage for eligible professionals from 50% of all non-controlled substances to 60% of non-controlled substances. So it's not a huge lift. It doesn't require e-prescribing of controlled substances. If you happen to do it, you can count them in your 60%. but we know that we're still, as a country, we got a little ways to go with getting two-factor authentication, the use of biometrics or hard tokens, which are required by the Drug Enforcement Administration for e-prescribing of controlled substances. So that's, yeah, fine. Go from 50 to 60, we can do that. The problem with this one occurs on the hospital side. So there's a requirement that 25% of all discharge prescriptions be done electronically from the doctor's brain to the patient's vein, going from the hospital to the pharmacy with no intermediary. Problem with that, for any clinician who is on the webinar today, you know that when you discharge a patient, you usually start their discharge worksheet the night before. You're thinking, oh, what meds will they go home on? What dose will they take? Oh, but then you change your mind. Oh, no, we're going to change this med. We're going to discontinue. We're going to start this one. We're going to change the dose. Currently, there is no pharmacy in America, basically, that can accept a cancel or change prescription transaction. SureScripts can do it, but the pharmacies can't. So actually, yesterday, Anthony, I checked with SureScripts just for interest. How many transactions total have been sent from hospitals to pharmacies in 2015 involving a change or deletion? 1,041 prescriptions total. And that's across 5,000 acute care hospitals and 330 million patients in America. So let's think. We did 1,000 of these in 2015, but we're going to now require every hospital to do 25% of all their discharge medications this way as of 2017. Probably a little unrealistic. So that one needs to be tweaked. Clinical decision support, actually the same as stage 2, making sure you have reminders and alerts that help you with a number of quality measures. So that one's not a lift. Provider order entry. That one in stage 2 was at 60% for meds, and now you've got 60% as well for meds, but you also have 30% for lab orders and for diagnostic imaging. The reason that one's going to be a little tough for some is that although we have reasonable standards for results coming back from a lab or RAD provider to an EHR, the compendia to order electronically are still not standardized. And this is interesting because, you know, LabCorp and Quest have actually totally different compendia for their service catalog of labs you can order. And so it's just getting every doctor to fully order electronically for labs and RADs is a bit of a lift. And so that went from a 30% stage 2 requirement to a 60% stage 3 requirement. Now we get into the areas where I told you we were going to see some controversy. Patient electronic access health information exchange. No one doubts that this is an important goal, and as a society, we need to do it. The wording, however, in the Meaningful Use Stage 3 rule is that 80% of patients must be able to view, download, or transmit their data, or you give an access to the patient to an application program interface so that they can, using an app on their phone of an arbitrary nature, get at their data. So I asked CMS, I said, this one's a little confusing to me. The way that it's worded, it basically says that hospitals can't refuse an app that knocks on the door asking for patient data. So let's just assume that the Chinese government issues a new app called stealmydata.com, and it adheres to a perfect API specification, and it comes knocking at the hospital door. Does the hospital have to then give up the patient's data? Well, yes, because otherwise you'd be information blocking. This one is nutty. You know, we all want to move to this idea where we're opening up our EHRs using novel standards to share more data for more purposes, and this notion of the Argonaut project or the FHIR, Fast Healthcare Interoperability Resources projects of HL7. This is going to take us to a set of software in hospitals and doctors' offices that looks a lot more like Facebook and Amazon and Google's ecosystem than what we have today of sometimes hard to interface systems. But requiring that patients now be able to just connect from their mobile device with any app to an application program interface is just premature. And again, I take my mother and say, hey, Mom, you better go download, this app so you can connect to the hospital's API so you can do a JavaScript object notation download of your FHIR-based medical record. Like, what? So this one, we really should eventually as a society get to, but let's prove application program interfaces and new standards in more controlled environments before we make it a patient-facing requirement. Then there's just part of this one is that doctors have to deliver educational materials electronically to 35% of their patients. It was 10% in stage 2. The reason this one's hard, at least for Beth Israel Deaconess, is we have 37 languages spoken, and we want to make sure we have plain language educational materials, typically written at the 6th or 8th grade level. Imagine trying to do that for 35% of your patients where your patients are very multilingual. It's a little challenging. Then the interesting care coordination through patient engagement criteria, remember I said that we couldn't do 5% view, download, transmit. Well, now stage 3 requires 10%. So I think that's going to be a stretch. And then it requires 25% of patients to do secure email. I have a feeling that there's going to be a lot of what I'll call ugly workarounds to this one if it actually goes forward. Like, we email a patient every time they are discharged from the hospital. You were discharged from the hospital. Oh, is that where I was for the last week? Just to meet the criteria as opposed to actually using it in a way that brings value to patients. Then there is a new requirement. This one will also be tough, that for 5% of all patients, you collect patient-generated healthcare data from their homes, their blood pressures, their weights, their glucometer values, sleep apnea monitors, whatever. Again, great idea, and Beth Israel Deaconess is doing this today with weight and glucose and blood pressure for selected patients. But we wrote the app. There was no app. And we built all the infrastructure around HealthKit as an alpha site for Apple. And so, fine, we self-build everything, and we have a lot of alpha tests done by MIT engineers who work for us. Probably premature to require 5% of all patients to submit electronic data as part of a standard 2-doctor practice in North Dakota. And then, as we get to health information exchange, there are 3 requirements. One, that doctors send, 50% of the time at least, for their encounters, the patient summary for transition of care. But then the 2 new ones are 40% of the time a patient visits a doctor, they must receive a transition of care summary from the last clinician who saw the patient. And 80% of the time, the doctor who is seeing the patient must reconcile the medications, problems, and allergies from all the external sites of care where the patient has visited. So again, these are not bad ideas, but a patient goes into a doctor's office. The doctor has 12 minutes to enter 220 structured data elements, 143 clinical quality measures, reconcile problems, meds, and allergies for the last 43 visits at 17 locations, be empathetic, never commit malpractice, and stare at the patient in the eyes. It is not possible. And I think what you're going to see is the AMA, the AHA, and professional societies saying, you know, we love EHRs, we love interoperability. We haven't as a society even got through the stage 2 process. Layering on top even more requirements onto a single practitioner is just going to result in more burnout and less patient satisfaction. Instead, can you give us an outcome you want us to achieve? Be less prescriptive about, oh, 80% of the time you need to gather this data, do this. What do you want? You know, medication error reduction? reduction in cost, patient satisfaction increased. So I think what you'll see is, again, lots of pushback on the Objective 6 and the Objective 7 here as we start thinking about maybe new approaches which are outcomes-based, and as we'll talk about in a second, those probably would be put into the merit-based payment program that's specified by MACRA, what's called Sustainable Growth Rate Fix. Finally, the criteria that's just going to be interesting from an IT perspective: eligible professionals must submit 2 kinds of public health transactions from a selection of 5 different types, and hospitals need to submit 4 different types from a menu of 6. And when I chatted with CMS, I said, CMS, okay, you're requiring doctors and hospitals to do all these transactions, and their EHRs have to support all of them, but you're not telling public health that public health has to actually standardize the way it receives them. And CMS said, yes, we have no authority over public health whatsoever. So let me get this straight. You're leading doctors to water, and you're beating on them until public health drinks. Does that make any sense? Let's do what the CDC did, which is the CDC outsourced all of our syndromic surveillance for Ebola to Amazon. Yes, all of your public health surveillance data today is on Amazon Web Services with a single user interface, a single set of data management, a single set of standards. Public health is going to have to standardize the way it receives these transactions, because otherwise the vendors and the IT folks are going to go insane trying to deal with the heterogeneity of every state and local public health department using different standards and different approaches for the collection of this information. So there you go. That was, I just did 1,500 pages of regulations in 15 minutes. I recognize that was a little dizzying. And I'm going to show you a slide next that you are not expected to read. This next slide illustrates the problem of the certification rule. ONC, very good, very well-meaning people, and their sense is that the ONC mission is much more than just meaningful use. It should actually be supportive of every government program. So the certification rule that they've written as a final rule for this sort of stage 3 time frame happens to include meaningful use requirements, but it also includes requirements that can be used in a huge variety of merit-based payment and quality measurement and public health programs from various federal departments. Now, why is this a problem? So it's true, you look at this chart, and it's just the center of the chart that says these are the requirements for meaningful use. But if a vendor like Epic or Cerner or Meditech or eClinicalWorks or Athena or anybody wants to say, focus the next 3 years on usability, innovation, new ways to reduce the burden of data entry for clinicians, they can't. Because, in effect, you have a rule that says, oh, for every potential government program, oh, these are all voluntary. But what's going to happen is customers are going to say, on page 453 of the certification rule, it says, if you want to send a transition of care to a nursing home, here's how you have to do it. Epic, get right on that, will you? Here's my hope. You look at this thing, and I've computed the burden on the industry. It's about 150 man-years of burden for every vendor. So Epic and Cerner, Meditech, eClinicalWorks, they all have to find 150 man-years of spare cycles to go implement this slide. The slide is voluntary. The only reason you need to certify any of your products are because there are going to be customers who want to achieve meaningful use at a station, and that requires certified electronic health record technology. Well, if, as I am predicting, the meaningful use stage 3 criteria are softened, delayed, or moved to a merit-based pay program instead of a penalty program, I suspect most hospitals and doctors will choose not to participate. And therefore, Epic and Cerner and Meditech and eClinical and Athena can go to their customers and say, guys, We could either work on usability and efficiency and improving the quality of your work life, or all this meaningful use stuff. It's optional and there's no penalty. Customer, what do you want us to do? And I bet the customers will just say, you know, forget this meaningful use thing. We're done. So that's my prediction. We'll get through stage 2, people will attest, hopefully then we won't have a penalty phase, and hopefully a lot of this burdensome certification stuff will just never need to be done. There's stuff, by the way, in this slide that includes standards that have never been used in production anywhere in the world. And we were very clear at the Standards Committee, ONC, you should never enumerate in regulation a standard that is immature, and yet this slide is filled with them. So fascinating, like one you'll see in the last column called data segmentation for privacy. Lovely idea. Suppose, and this is not true, Anthony, you have a medical record with a flu shot. That's pretty boring. Oh, but it also has mental health, it also has substance abuse, sexually transmitted disease, and domestic violence. You decide that when you go see your dermatologist, you will share data about your flu shot, but you'd rather not share the substance abuse history. Data segmentation for privacy enables a medical record to be stratified by type of data. It's just really, really hard to do. How do we know if your problem list, medication list, allergy list, the notes, the labs imply a disease state you don't want disclosed? It's just hard. And so, yeah, it's a great idea, and yes, we should work on it as a society, but it's way premature to include in regulations. So that's the cert rule. So let's just go through a couple other items, and then we'll turn it over to our friends at Lexmark, and then we'll do Q&A. ICD-10, of course, went live October 1st. All of us went through that, and I can tell you from the hospitals in Massachusetts, from all the payers that I talked to, really, there's not been much consequence. And that is to say, we're not seeing increase in denials. I mean, there are a few, but it's not substantial. We're not seeing reduction in cash flow at the moment. We aren't seeing the fact that a lot of the codes that are being used are not totally specific, that somehow it's going to reduce the amount you collect. Not quite happening. Maybe next October, when CMS starts the RAC audits again, and we have auditors determining if we have documented the bird species and whether it was a subsequent visit where you were eaten by a shark, you know, those sorts of things might result in more burden a year from now. But for now, it's okay. Of course, as I often write about, the great lie is that ICD-10 has benefit. We're all doing it, but it is, I guarantee you, not resulting in a higher quality of data for the computation of quality measures or any kind of analytic. I mean, it's way too complex a code set for most mere humans to understand, and so doctors are probably coding what they're used to coding, and maybe in the future that will reduce the reimbursement. It's certainly not going to help anyone. HIPAA omnibus rule, we are seeing OCR cranking up for its second round of intensive HIPAA audits. So recently I know that in Massachusetts there was an $850,000 settlement at one hospital group because it was stated by OCR that they did not have a robust enough education program. And recognizing that getting the HIPAA omnibus rule understood by all of your employees is a huge educational effort, and they hadn't done it. So watch for more fines and for more audits. I mentioned the idea that stage 3 may be moved into some kind of merit-based pay program. So you've got the Medicare Access and the CHIP Reauthorization Act, or MACRA, which includes a variety of moving from fee-for-service to the idea of alternative payment models, and therefore this notion that, hey, we'll pay you for an outcome. We'll pay you for quality. If you want to buy all your 80-year-olds Apple Watches and watch to see if they're walking, and then if they're not, enroll them in an exercise program, go for it. If you want to send high school students to their front door with a clipboard doing a survey, that's okay too. We're not going to tell you how you achieve the outcome. We're just going to pay you for the outcome. That, I think, would be welcome by a lot of doctors and hospitals. And finally, there's a lot of new precision medicine activity going on in Washington with the idea that you, the patient, have a medical record, have preferences for care, have a genome. And with that data combined, we can then say, here is how you should best be treated. And today, we're doing a lot of protocols, guidelines, and such, but they're more generic to a population, not specific to a person. So more and more coming on the data standards and flows and technologies supporting precision medicine. So, Anthony, that was the 1,500 pages of regulations, ICD-10, and all the major Washington updates. I guess the only other thing to say is Congress is very frustrated these days. They aren't quite sure we got our money's worth with the $31 billion spent on healthcare IT. So the Senate Help Committee is really looking at all the regulations over the last several years that we have created for the healthcare industry and asking, might there be a better way, a simpler way? So you may see some relief coming from Congress. So back to you.
All right, very good. We're going to move along to our next segment, but before I do, I just want to say Dr. Halamka's example of my medical record is theory and not totally accurate, so let's leave, leave it at that.
Of course.
Of course, of course. All right, well, we are now going to turn it over to Darren Sinkler, Healthcare Industry Director with Lexmark, and Lexmark is sponsoring this event today and making it possible. So, Darren, thanks for joining us, thanks for sponsoring, and we're looking forward to hearing your message.
Yeah, thanks, Anthony, and thank you, Dr. Halamka, for a couple things. Number one, not using me as the example in your reference earlier, and we do appreciate your insight and your education and all the work that you do. So much appreciated. Well, good morning, afternoon, everybody. I am the Solutions Director for Lexmark Healthcare, and I couldn't be more excited about the opportunity to continue to work and drive, our solutions with clinicians and IT staff and our developers and partners around the globe on interoperability and information access. And speaking of, helping you all obtain and meet your objectives around MU2 and 3 and beyond. So with that, I've just got a couple of slides, and then we'll get to the Q&A portion. I did want to, we talked about this earlier, and I did want to kind of introduce or reintroduce you to Lexmark Healthcare. Many of you may recognize the Lexmark name as a technology leader in the managed print services and printer arena. And, many of you probably have Lexmark devices in and around your hospitals today. However, Lexmark over the last 4 to 5 years has really diversified their portfolio of solutions and really moved more into the enterprise software space in healthcare in particular. And they made 4 key acquisitions over the last 4 years that really represent kind of their breadth and depth of portfolio of solutions in this arena. So you may be familiar with companies by the name of Perceptive Software, kind of a leading document management system provider in the healthcare space for quite some time. Accio Technologies, a market leader in the vendor-neutral archive space. PACS Gear, which they've been in and around the PACS environment delivering and providing image connectivity solutions for radiology, cardiology, and other areas. And finally, Claron Technologies. They offer a world-class, best-of-breed, zero-footprint, both diagnostic and referential reviewer around the planet today. So with those 4 key technologies that Lexmark has really invested in, we all sit in the enterprise software division of Lexmark under that umbrella, but we are all dedicated and drive healthcare solutions in the regards to content management. We talked about, and I was listening to Dr. Halamka talk about, information and access and those types of things. And I do really want to stress that, it's interesting that we not only see that the storage size of key pieces of information have grown, but that really the demand to access this information, whether this is being driven just from patient need or a radiologist or HIM or physician need, or from MU2 and 3 type of objectives. But information is vital. It's key to everything that we do. And to have that information that you need intuitively and in the context of your already familiar workflows and systems make really all the difference, and that's what we're doing. Just a quick gratuitous factoid slide I like to throw in here, just to continue to reemphasize who we are to you as Lexmark Healthcare. So I won't read all this to you, but I do want to point out a few key pieces of information. Lexmark Healthcare, we are the #1 independent VNA market leader on the planet. We have over 1,200 plus hospitals using our VNA and over 2 billion studies under management. And we capture, manage, and help you store your PACS images and then can send them back to your PACS, to your viewer, to our viewer, and or to your EMR for reference and viewing. We work with EMRs like Epic and Cerner and Allscripts. We also have document imaging management and workflow products and very mature integrations for major ERPs like Infor, Lawson, Workday, and PeopleSoft. I mentioned the PACS products too. We have image connectivity solutions like video capture, visible light, DICOM share exchange solutions that are in operation all around the U.S. The last thing I would note, we just came off of a very successful RSNA up in Chicago, and we really were highlighting our zero footprint diagnostic and referential reviewer for cardiology and radiology and all the other ologies for that matter. So in summary here, I guess, when you think of capturing, managing, sharing, and viewing your clinical content, that's what Lexmark Healthcare does. With that, I'd like to end it. I'd like to encourage you all to visit our website to learn more about our solutions and start to familiarize yourself with not just Lexmark as the company, but and certainly the enterprise software division of Lexmark under the healthcare umbrella, and see more about our solutions on our website. So with that, Anthony, I'll turn it back to you.
Thank you very much, Darren. Appreciate the sponsorship and appreciate the message. So once again, thank you. Now we have a little time for our Q&A with Dr. Halamka, and as you'll see on this slide, he is quite an accomplished gentleman and a good friend of ours. First question, Dr. Halamka, when will the Stage 3 final rule drop?
Well, of course, it has, as a final rule, already dropped.
Right.
But as I think what the question is really asking is, when will the comment feedback be used to change the path forward? The comment period closed in the beginning of the month, and so generally my experience is about 90 days after the comment period closes where you start seeing some feedback. So yeah, I would guess that we'll see in spring some feedback from CMS, either, again, delaying, suggesting that this get rolled into merit-based pay. I don't think it's going to be just eliminated altogether. That they would need to save face. But we'll see overwhelming negative feedback, and they will have to address that in the spring, early summer.
Now, you mentioned that a final rule with comment period means it's not final, but it's also a possibility that a final rule with comment period means the comments go in the garbage.
It won't happen. I mean, it won't happen, right? I mean, you're seeing 5,000 hospitals and 500,000 doctors all saying, hell no, we won't go. I just can't imagine. I mean, the macro program, which really shapes the future of American medicine into a alternative payment, pay for quality, pay for outcomes model, is just not aligned with Stage 3. And CMS knows that. So they're in this sort of awkward place where they had to get out a rule because the Stage 2 stuff wasn't working so well, and therefore they put out one rule which fixed Stage 2. The Stage 3 stuff just wasn't ready for prime time, and they know it.
Has anything slipped through to complete final status that should not have in this program? And do you think anything, if you get something so egregious as Stage 3, is it possible one of the things gets through? What are your thoughts on that?
No, it's interesting that I think, looking back on the 2009 to the present period, Stage 1 was fine because it said every person should move from paper-based documentation to electronic documentation with a basic set of functions, problems, meds, allergies, and that sort of thing. We should have left it there because when you start now requiring, you attempt to change culture and behavior through regulation, it never works. And so this notion of, we're continually changing our mind as to what quality measures we're going to use and how we're going to measure quality, and we're going to try to engage patients and families by making it a regulatory requirement of the doctors as opposed to looking at the value proposition to the patients. We're going to require a vast number of data entry elements without thinking about usability and impact on workflow. So, I think all of us are going to, because they're watered down, get through stage 2. But I think history will record that stage 2 did not improve quality, safety, or efficiency at all. And that stage 3 really just shouldn't go forward. So it's not one aspect of it that I think is negative. It's the idea of highly prescriptive behaviors as opposed to a focus on outcomes that was wrong.
How do you think it gets there? I mean, these are good people, as you mentioned. They seem to have a lot of input, although I've always questioned the makeup of, how they decided on the makeup of some of the advisory panels and who gets to represent, 2 people from this group, you remember, from the beginning, and 2 people from that group, and then they were political appointees. Is that the core of how things get off track to the left or the right? And just your thoughts on when you see things like this come out, are you surprised that they missed the mark so much?
So the advisory committees are actually fine, right? If you actually look at the recommendations the advisory committees make versus what actually ends up in regulation, you'll see there's a disconnect. And the reason for this disconnect is, you've got Congress providing pressure. My daughter went to an emergency department in Texas and her California record wasn't available, and oh my God, how could this happen? So Congress offers pressure. But then 25 federal departments each have their own specific needs with their own specific pet projects. So what you end up with is this sort of immense amount of special interest pressure to get something in a regulation. That's the problem. In effect, meaningful use became a dumping ground for special interests inside government and outside government to get their pet project into regulation. I think that's why we should have stopped it after stage 1, so we didn't have a vehicle for that kind of special interest activity.
Let's talk to me a little bit about what is in the realm of possibility, reasonable possibility, and what is not in terms of what can be changed. And I guess, can we put a line here and say what can be done without legislation, and some things that you may want to be done would require legislation, and perhaps that just won't happen. Can you lay that out for us a little bit?
Right, and so this is, as you say, the problem. That is, if we say, because of ARA and high-tech, there had to be certain aspects of the Meaningful Use program that went forward, and it can only be reversed with legislation, getting legislation of any kind through Congress is just really hard. So you really want to try to avoid that at all costs. So what you hope is there's regulatory and sub-regulatory action taken. And let me give you an example of how it can work. In the Sustainable Growth Rate Fix, there was a whole set of pages how every doctor in America must use radiology decision support when ordering an MRI, CT, or PET scan. You can't actually order one until you go through some decision support system. Well, that's fascinating, except no EHR supports that workflow, and there are no services that actually provide that today. So how could you require it in a regulation? And CMS said, we recognize that whole provision in the SGR fix. It's just not going to work. So we're going to put it on indefinite hold. It sits in the regulation, but we won't enforce it ever.
Right.
Okay. So there's nothing wrong with leaving Meaningful Use Stage 3 on the books. Just don't ever penalize anyone for not doing it.
All right, I want to take one more. Oh, go ahead, I'm sorry.
I just think that's what CMS is going to do. They'll be realistic.
I want to get one more audience questions in front of you before we wrap. In most communities, we are driving patients crazy with multiple patient portals, thus making patients like our elderly patients, and you referenced your mother, although she might not want to be called elderly, remember username and passwords for hospital practices, HIEs, etc. When do you see universal patient portals coming? And the individual said, regarding my question, I know Beth Israel has developed the app for Universal Patient Portal, but I rarely see that in most communities. My question is regarding most communities.
Right, and that's, I think we all agree is the point about application program interfaces and the ability to get data as opposed to get a web page is a good trajectory. It's just too early. So what I would say is recognize portals kind of get the job done for the short term, but aren't ideal. So give us 5 years as a society to develop such things as trust. How do I decide what apps I can trust? Which are good enough? How do I figure out what data is actually valuable to the patient? And then, 5 years from now, with new standards and new policies and new technologies, we will be able to export the data seamlessly into an app that a patient can then use as the steward of their own data. It's just not next year. It's more like 5 years away.
Very good, excellent. Well, we're gonna wrap it there. I want to thank Dr. Halamka for providing these invaluable updates, and we've heard some comments from the audience indicating how happy they are that you're doing these for us, Dr. Halamka. I want to thank Darren Sinkler and Lexmark for sponsoring and speaking. And again, sponsors make these events possible, so definitely check out Lexmark. You'll receive an email when our recording has been posted to YouTube. If you've got the CHIME CHCIO certification, attending our webinars gets you 1 CEU for each event. Let CHIME know you attended, and if you've asked us to do so, we will. Sponsorship opportunities, contact Nancy Wilcox. Questions, comments, you can reach out to me. And when you close out your WebEx window today, you will see, I believe, 1 or 2 windows pop up. Take a look at ours. We've put together a quick post-event survey. So if you take a minute to answer that, it helps us make these better, and it also helps us demonstrate to the industry that we're doing a decent service here. So we would appreciate you filling out that survey. And you can go to our website to view our upcoming schedule. So once again, I want to thank Dr. Halamka, Darren Sinkler, and our audience, and everybody have a wonderful day.
Thank you.
Thank you.